So this last little part has to do mostly with stroke and diabetes. So we think of stroke as being a neurological problem and diabetes as being affected by the endocrine system, but both of these result in altered mental status. So I know we talked about altered mental status. I'm just going to bring them back into play here. And then I left in the abdominal pain, which is at the very end, and it only had a few slides. So I think this will make sense. The third leading cause of death in the United States from a non-traumatic problem is stroke, and it's a brain injury. It can be caused by a blood clot that blocks that blood supply to the brain, or it can be caused by like an aneurysm, a bleed that that area of the brain bleeds out, and less common. Most of the time it's a clot, but less common it can be that. But since the skull cannot swell, the blood doesn't have much place to go, so they don't usually bleed out from the aneurysm. It kind of, tamponades itself in there. But either of those are causes a disability on one side of the brain, the right side of the brain or the left side of the brain. So one thing to think about is our brain controls, the right side of the brain controls the left side of the body, and the left side of the brain controls the right side of the body. And it bridges about the bridge of the nose, meaning that if you see the right pupil fixed and dilated, you shine a light in and it's just huge, it doesn't change, but the deficits are on the left side of the body, they probably have a right-sided stroke, and inverse on the other side. So common signs and symptoms. They could be dizzy or confused. Because of the facial droop, flaccidness, they may start drooling. Here's a big one. They have a sudden onset of numbness or paralysis on one side of the body, just really weak. So one of the assessments that we're going to do is we're going to give them 2 fingers from each hand. Our fingers, our hands, put out 2 fingers and say, squeeze my finger. Don't give them 3 because they can really squeeze hard and it hurts. Give them 2. And then measure their grip, their equality when they squeeze. Sometimes they can't even move that side. They may report difficulty seeing. Unequal pupil size, so check the pupils. For the most part, it's a sudden onset where their mental status has changed. They may become real confused, unresponsive, difficult speaking. They may even have a seizure from it. So one of the things about strokes that's really bad is most of the time somebody has a stroke that affects their abilities, what we call cognitive abilities, their abilities to tell you who they are, to tell you what day it is, to communicate with you. And other times they have a stroke that affects their body, like their body becomes very weak, especially on one side, but their brain is intact. So don't ever think because somebody is unconscious that they can't hear what you're saying. So just like a patient that is sitting there looking at you, you wouldn't say, oh my God, he's having a terrible stroke, he's probably going to be disabled the rest of his life. You wouldn't say that to somebody who's unconscious. They may be able to hear that. People who have strokes might also become incontinent and have respiratory problems, may even go into arrest. So we use a scale to determine whether or not a patient may have experienced a stroke, and this is called the Cincinnati Pre-Hospital Stroke Scale. It's very easy. Doesn't require any special equipment. So the first thing, I'll walk up to see somebody and introduce myself. How are you doing today? And try to get them to speak to me, just to get some kind of an assessment. And then I'll ask them, hey, can you make a big smile for me? And if one side of the face goes up and the other side doesn't go down, we call that facial droop. I'm going to tell them, can you repeat a common phrase for me? And one of the most common in English, there's others that are in Spanish and other languages, but you can't teach an old dog new tricks. And they may use incomprehensible words. They may have slurred speech. And that's something that we take note of, that they're unable to articulate words. And I'm going to have them squeeze my fingers, and if they're able to do that, then I'm going to have them hold their arms out straight in front of them, kind of like you'd see like a mummy walking. Close their eyes, and then tell them to hold their arms up like that. What will happen, if they do have the strength to move both arms, when they close their eyes, their affected arm, the affected side, that arm will drift down. Most often when you do this test, they're only able to move one side, one arm, one leg on one side. And we call it hemiparesis, or if they're completely paralyzed, hemiplegia. Heme means half. If they're positive to any one of those tests, they're positive for a stroke. So here's the Cincinnati Pre-Hospital Stroke Scale. It's in your book, and it shows you normal and abnormal on here. Any one of those, if they have facial droop but they can move their arms fine and they can speak fine, it's still positive for a stroke. So treatment, first thing is to make sure they have an open airway and give oxygen. Now, there's a lot of controversy right now going on. This is 2016 about giving a non-rebreathing face mask. That's going to deliver 90% oxygen. So if they need it, if they have air hunger, labored breathing, by all means give it to them. But if they don't, if their room air sats are good, you check your own protocols with your own medical director, but a couple of liters of oxygen or no oxygen is actually better. Oxygen shrinks the blood flow to the brain, the vessels to the brain. So if we give them too much oxygen when their brain really needs it, it cuts it off in the way of the blood. So look at your own protocols for that. But right now we're saying low flow O2 if they don't have any need for it, or none at all. Be alert for seizures. You know that could happen anytime. Be alert for rescue breathing. Be alert for vomiting. Patients that have strokes are known to not only vomit but projectile vomit. So if they're unresponsive, I want to put them in the recovery position, preferably on the affected side. Like if they show me their left side was weak and now they're unresponsive, even if they're responsive, I want to put them on their affected side. Here's why. If I had a stroke and you put me on my left side just because Susie's been drilling it into you, put you on your left side, and then I'm paralyzed on my right side, I'm laying there going in my mind, remember, sometimes it's the body and the brain is completely intact, we just can't communicate, and I'm going, man, I'm screwed. I'm here in this trapped body, I'm paralyzed everywhere. Whereas if you put me on my paralyzed side, the affected side, and I go to scratch my ear, I'm like, I'm not doing too bad. I'm able to move my hand, and it relieves a lot of that anxiety. So talk to the patient, touch them, encourage them. You can touch your hair, scratch. Okay, I see that I can. I'm doing better with that. So we want to get them to definitive care, to a stroke center that if they had a blood clot, and they'll find out by doing a CAT scan, a head CT. First few minutes when they get to the hospital is what they're going to do. And if they have a clot, they want to, similar drugs that they gave to dissolve the clot in the heart, they want to give those drugs to dissolve the clot in the brain. So just like time is muscle in the heart, time is brain, the longer they've had that stroke condition, the less likely they're going to have any recovery from it. So your job as an EMR is to find out their last known well time. It's so important that this gets communicated because this tells them tells the receiving staff whether or not they're a candidate for the clot busting drugs. And here's the thing that happens though. A family member says they went to lay down an hour ago with the worst headache of their life. We hear that a lot, worst headache of their life. And I heard some noise, like they started snoring really irregularly. You could hear it. And I went to check. I couldn't wake them up. So when did the stroke happen? Well, I think the stroke happened 30 minutes ago whenever I couldn't wake them up. No, the stroke happened when you last saw them, the last known well time. So we say, what time did they go lay down? And not about 3 o'clock. I need to know, well, the news came on and it was already past the main part. So I'm going to say like 3:10. And some services will even take a Sharpie, a marker, and write that number 1510 in military time on their forehead, so everybody that communicates with that patient understands that's their last known well time. And it's real important for these. Good chance of recovery if we get these taken care of very early on. Otherwise, the best that they can hope for is good rehab. Strokes change the rest of their life. Most strokes are evil at the damage that they do to the body. So we want to make sure to get them to definitive care as soon as possible. Diabetes can also cause altered mental status. And diabetes is the inability of the body to process and use glucose because of the lack of insulin. Insulin is produced by your pancreas, and some people that have insulin deficiency, like true diabetes, those large sugar molecules stay in the bloodstream. They need the insulin to help make it pass from the bloodstream to the target tissues and cells that need it. So those cells actually become starved for sugar, and that's why we say sugar diabetes or high blood sugar. Well, some people that have diabetes, they really have to regulate between the high and the low. And a good rule of thumb with diabetics is to check the sugar every day, number one. Stay on the medications. Use the food exchanges. The simple carbohydrates, the breads and the potatoes and all like that, they could still eat them. They just have to have them less often and less amount. But diabetics have to eat every 4 hours. There's no ifs, ands, or buts. I mean, you may be able to wake up and by 2 o'clock you have something to eat, and you've been working for 6 hours. They can't do that. They will use all of their residual sugar reserves and starve their brain, so it's not good. So signs and symptoms of low blood sugar we call insulin shock because it looks a lot like shock. Pale, moist, cool skin. Look at that. What if it's 72 degrees in the room and they're sweaty? You'd be like, man, why are you sweating? It's cool in here. Well, yeah, they're showing signs of shock. It's a body's reaction to stress. Rapid, weak pulse. They could be dizzy or have a headache. If I skip a meal, I have a headache. So think about that. They can be confused. They actually get quite combative. The cool thing is, I guess it's cool, is because they're lacking energy in their body in the way of sugar, they're not very strong. So they'll actually appear intoxicated, slurred speech, trying to fight you, and some family member says, oh, he's got diabetes. Well, when was the last time he ate something? Well, he didn't feel good because he threw up earlier and he went to bed. Well, it's probably low blood sugar. So if you have a service or equipment where you can check a blood sugar, we want the normal to be between 80 and 120. And when it's less than 60, we call that low blood sugar. And that's probably what happened to them. If you ask them if they're hungry and they're able to communicate, yeah, they're hungry, they haven't eaten. But the big thing about low blood sugar is how rapid it sets in. I mean, they can be talking to you 1 minute and on the floor the next. Getting them help within a few minutes is really important. The brain can't go very long without sugar. The longer it's deprived of that, the more damage there is to the brain and the tissue. So if the patient's awake and able to swallow, have them eat or drink something sweet. The best thing is fruit juice, so like an orange juice or an apple juice or a grape juice. That fructose gets readily absorbed in the body so much faster than anything else. Second would be a sucrose, like a soda. That would work. Make sure it's not a diet soda. And that's just going to buy them a little bit of time. They still have to eat something that they would normally eat, a sandwich or something like that. If they're unable to swallow, don't force any fluids down their mouth. Remember that airway issue? Airway, breathing, circulation. Well, the airway is utmost important, so you don't want to have them choke on anything. Some people will have their own glucose or glucose tablets, or people will carry rescue snacks because they know what works for them. But if they're unconscious, we can't give them anything by mouth if they're unresponsive, if they can't protect their airway. So think about those kind of things. So even oral glucose or the tablets, they have to be able to protect their airway. You can't give that to somebody that's unresponsive. When somebody has high blood sugar, this is not as much of an acute event, meaning that they live with high blood sugar for the most part. Some people that don't know that they're diabetes, there's a little 7-year-old boy in your neighborhood that he goes to a birthday party, has cake and ice cream and all this stuff, and over the next few days, the mom notices that he's eating a lot, but he's losing weight. And he's going to the bathroom a lot because your body's going to burn something for fuel if it can't burn sugar, and it burns fat, which you think, well, that'd be nice, right? Except when it burns fat, it's an alternative fuel, and it causes a buildup of acids called ketones. Well, ketones are a poison to the body, and the body does everything it can to rid itself of that. So they'll actually sweat it out of their skin sometimes. You can smell it in their skin. They'll pee it off, so they're going to the restroom a lot. They dehydrate, so they drink a lot of fluids. You can smell it on their breath, the fruity ketone odor on their breath. So usually they have a history of diabetes, warm, dry skin, rapid pulse with deep breathing because they're trying to get rid of those ketones. They may be weak and nauseated. They may even vomit. But the biggest thing is they're going to be hungry. You're like, oh, you just ate. How can you be hungry again? Well, all that sugar is in the bloodstream, but not in the target tissues. They don't have enough insulin to help it pass from the vessels, the bloodstream, into those target tissues. Because they've been urinating a lot, they're thirsty. So they'll actually tell you they're thirsty. It's a very slow onset, number of days that this happens. If you have an AccuCheck a glucometer, you can check the sugar, and it's usually going to be high, over 150, sometimes really high, over 400. We call it diabetic ketoacidosis. But oftentimes when you look at patients that have altered mental status, it's hard to tell, is it insulin shock, low blood sugar, or high blood sugar? So if they're awake, we have to give them sugar if we're not sure. Because to have high blood sugar is not as dangerous as to have low blood sugar. If they're unresponsive, then we can't do anything for them other than call for an ambulance, hopefully advanced life support. And if it's low, they'll give them IV sugar. If it's high blood sugar, then they'll give them fluids to replace their dehydration that they have. So kind of a little bit of a comparison on this table between the two. And, the advent of us being able to carry glucometers, that's really ruled out a lot of this guess of which one it is. But conscious diabetic patients, if we can't say that for sure it's high, we're going to give them something sugary by mouth, and unresponsive, we're going to transport. A very common thing, diabetic complications. Moving on into abdominal pain, there's just a few slides on this, and then dialysis, and that kind of wraps up this whole module on medical emergencies before we get into some of the other, what we call specifics, like allergies and environmental and behavior specific problems with that. So we look at the abdomen, we divide it into hollow organs and solid organs. And the hollow organs, like the stomach and the gallbladder and the intestine, their job is to hold things. Whereas the solid organs, like the liver and the spleen and the pancreas, those are very vascular. They have a lot of blood through those. So any of those organs, hollow or solid, can cause pain. And abdominal pain, believe it or not, is a very common medical complaint to receive a 911 call. So there's a number of things that can cause it. It can, be caused by something that they ate, like a gastroenteritis, causing nausea and vomiting and diarrhea, or it can be caused by, a gallbladder where they have gallstones, and it causes abdominal pain. It can be caused by a number of things. If somebody vomits blood, this is not normal. If they vomit blood, it means that they're either bleeding from the esophagus or the stomach, and we call that an upper gastrointestinal bleed or an upper GI bleed. So they're bleeding internally that we can't control that bleeding. That's a bit of a problem. Keep them comfortable, watch that airway, watch them for vomiting, and, arrange for transport because they need to get someplace really quick. The lower GI bleeds, where the bleeding comes in the form of the stool, where there's bright red blood or coagulated blood or dark blood, like they digested it from that upper GI bleed, that also can cause somebody to go into shock. So both of these need rapid interventions. Some people have what's called a AAA, abdominal aortic aneurysm. So even though it's abdominal pain, it's really circulatory in nature, not so much gastrointestinal. And a lot of older men, especially 50s and 60s, will complain of flank pain, like to the sides of their lower back. And they may have difficulty urinating, and those are telltale signs of a AAA. Risk factors for these: diabetes, high blood pressure, atherosclerosis, and heavy smoking. So if this thing ruptures in the field, there's nothing you can do. They will bleed out from that aorta very fast. So don't be prodding around, feeling on the stomach, feeling for a pulsating mass or anything like that. Anything under pressure can rupture, and we don't want that to happen. Let them get in the most comfortable position, treat the patient for shock, and arrange for prompt transport. If you suspect a AAA, these people have to go directly into surgery, so think about where you're sending them to. This would be a good candidate for air transport, air ambulance. There's a lot of people now that had uncontrolled hypertension, high blood pressure, uncontrolled high blood sugar that didn't take care of themselves, and now their key organs are failing because they're losing their vision. Their circulation to their feet is poor. They're starting to have amputation of their feet and toes and legs. And kidneys will start to fail. So if the kidneys are unable to filter waste products and take care of the water distribution and balance within the body, then fluid's going to accumulate. And these people have to undergo what's called hemodialysis. So they go 3 times a week. Usually it takes about 4 hours. And they can't live without it. It's not like, oh, I don't feel like going today. They can't do that. So a lot of the patients will have a shunt implanted in typically their arm. Make sure that you don't take a blood pressure in that arm. It doesn't matter that it's in the forearm and you're taking the blood pressure in the upper arm. It doesn't matter. If you restrict the blood flow to that, you can damage that shunt. They would have to have it replaced. So it's surgically created, and it's a connection between an artery and a vein that in dialysis, the techs can access that point to hook them up to the dialysis machine. A lot of people that have that undergo dialysis have problems from this. So when they go in, they have to be weighed. They have to be checked for their fluids. When they leave, they're weighed. They're checked. Everything. Their blood pressure, everything is checked so that they don't have any complications from this. So a big thing that can happen, especially if they miss a dialysis treatment, is they get not only an accumulation of fluids, but an accumulation of electrolytes, like increased potassium, which can cause some cardiac arrhythmias. So these are common with patients that are undergoing dialysis. It's really sad to see a lot of young people on dialysis, and they're on transplant lists for kidneys. A lot of times a family member will donate 1 kidney. We can live just fine with 1 kidney, so that they can have a fairly normal life again instead of having dialysis so often. So these were some of the medical conditions that we wanted to talk about: altered mental status, cardiopulmonary problems, and then this last little bit on strokes and diabetes and such. We've got more to talk about as far as medical emergencies into chapters 10, 11, and 12. But this kind of gives you an overview of and some specific on especially the really hard ones that you're going to come in contact with, like you get a call for difficulty breathing, you get a call for chest pain, you get a call for a confused person, altered mental status, and then lastly abdominal pain. So let's look at the little bit of review questions from all of these. Signs and symptoms of a stroke include all the following except. See how it's bold, it's capitalized. So numbness or paralysis, yes or no? Yes. So that would not be an except. That's good. High fever. I didn't say anything about high fever, did I? So that's a no. Drooling, yes, especially if they have the facial droop, and unequal pupil size, fairly common. So the one thing in there, high fever, is not a common sign or symptom. Oftentimes they complain of headache, but not a fever. Which of the following actions would not be appropriate when managing a patient who is suffering a heart attack? Placing the patient in the most comfortable position, that's a good one, but it says which of these would not. So not pick that one. Administer oxygen if it's available, that's a good thing to do. Be prepared to administer CPR, yeah. Move the patient as quickly as possible to the ambulance for transport. Boy, that's a tricky one, let me tell you why. Yes, I want to get him to the ambulance. Yes, I want to get him to definitive care. But by moving the patient as quickly as possible, I'm scaring them. And if we drive really, really fast, where you scare me too, then, I'm just increasing their anxiety. So move them, but explain everything to them. You don't have to run lights and sirens the whole way. Let them know we're doing everything that we can for you, but if you remain calm, they start to calm down too. Insulin shock, this is the low blood sugar, occurs when a patient consumes too many high-fat foods. It has nothing to do with high fat, right? It has to do with sugary, and this is somebody who lacks sugar. So that's not it. Has enough insulin, yes, but not enough blood glucose. Ooh, that's true. I like that one. Suffers severe dehydration. You usually see dehydration with the high blood sugar because of the body trying to rid itself of those ketones. Has too much blood glucose but not enough insulin. Yeah, it looks like it's going to be B. They have the insulin that's needed, but they just haven't eaten. They haven't eaten often enough. And again, the best thing for diabetics is to have a constant supply of, because they can't store it as well, of sugar. So every 4 hours they have to, it doesn't mean they have to have a smorgasbord or a buffet, just something in their system every 4 hours.